Thank you, Carlos. So it's my pleasure to present to you today a joint effort of 4 groups in Germany recruiting the largest trial in elderly patients with breast cancer that has been conducted so far. So the ICE study is a phase 3 study that compared ibandronate with or without capecitabine in patients being 65 years or older, having either node-positive disease or high-risk node-negative disease, and to exclude those patients that are too vulnerable to receive any kind of chemotherapy. We excluded patients with a high rate of comorbidities, and that was measured by the Charlson index. So Charlson index below 2 or equal or below 2 means that these patients that they have some risk factors, but still are feasible to get kind of monochemotherapy. However, these are patients that were considered by the investigators of not appropriately fit for receiving a conventional anthracycline taxane-based chemotherapy. So the conventional dose of capecitabine was used, and we allowed 2 modes of application of ibandronate, either orally or as an IV application, and that was chosen according to the preference of the patient to find out which is the most appropriate way of giving this bisphosphonate to this patient. And the reason why we have chosen this backbone of ibandronate was mainly to avoid an untreated control. As usual, this is not very helpful in convincing patients to participate, but on the other hand, we believe that these patients are at risk for bone-related events anyhow, and also they're also at the time in 2004 when we started the trial, there was quite some evidence that bisphosphonate in elderly patients might prevent breast cancer relapses. So the 1,358 patients are very well balanced, and you can see here that this is really an elderly population with a median age of 71. 1/4 of these patients were older than 75 years of age. 10% were somewhat frail with the comorbidity index of 2, and 15 to 17% of patients showed that they have some reduced physical function and some disabilities, and that was measured by the VAS13 score. The tumor characteristic, as you can see, demonstrate that these are not low-risk patients. They all have some kind of risk, but still 80% of these tumors were hormone receptor positive, and most of these hormone receptor positive patients received aromatase inhibitors. Bone-related events, that means fractures, surgery, new osteoporosis, but not the diagnosis of bone metastasis, were still frequent despite this preventive use of a bisphosphonate and occurred in 25% of the patients during this median observation period of 25 years. This was not different between the treatment arms, but you can clearly see that, and this is known, of course, that if patients were treated with an aromatase inhibitor, that bone-related events were more frequent than in hormone receptor negative tumors or tumors that patients that were treated with tamoxifen. Regarding the preference of the ibandronate application, you can see that 2/3 of the patients have chosen the oral application, and that remained stable throughout the 2-year treatment period. Only very few patients switched. And of course, of importance, the mean time on treatment is quite comparable between the 2 forms, 20.9 months with the oral and 19.6 months with the IV application. This is the primary endpoint of the study, invasive disease-free survival. You can see that at 3 years, absolutely no difference between the treatment arm was observed, whereas after 5 years, the curves seemed slightly to separate with an absolute difference of 3.8% in favor of capecitabine, but thereafter the curves are crossing, and therefore the p-value is 0.70, and though there's no statistically significant difference between the two treatment groups. And this is also the case if you look into subgroups. The most interesting subgroup probably is the one with the hormone for the hormone receptor negative tumors. Unfortunately, only 20% of patients had hormone receptor negative disease. So the power to show an effect here, where the events are coming more frequently and also more earlier, there is no difference. But maybe there is a trend, and this definitely leads to the conclusion that these patients have to be followed up further, as we know also from other capecitabine studies that long-term follow-up of adjuvant after adjuvant treatment is necessary to see these differences. However, in general, we can observe that despite this elderly age at randomization, and at the time of analysis, these patients were in median almost 77 years of age. They had a very favorable overall survival, 88% at 5 years, and this clearly demonstrates that these patients have a sufficient life expectancy, that they should be treated sufficiently and according to the best options regarding their breast cancer. And together with the previously presented result of CLGB-49-907, that was a study that compared capecitabine with combination chemotherapy EC, CMF, and found, especially for the hormone receptor negative tumors, more benefit for the combination chemotherapy. Taking these two trials now together, a combination chemotherapy is strongly supported, even in patients that have a higher age at diagnosis. Thank you very much.
Thank you, Gunter. May I start with the first question? Do you think this follow-up is long enough for patients with hormone receptor positive disease?
I don't think so. We know that in many trials the treatment effects in hormone receptor positive disease occurs after 5 years, and actually what I showed, that the curves are starting to separating now, is probably a signal that we definitely have to go for 10-year follow-up to fully assess the benefit of the treatment, but also to collect, of course, late side effects to have an appropriate risk-benefit assessment.
Thank you.
Great. Now moving to questions from the room. If you're in the room, please wait for a microphone. Michelle, you got the first question as soon as you get a mic.
Excuse me, it's the first time I've spoken this morning. I actually have two questions, if I may. The first question is, traditionally, our elderly patients who have some a little bit of frailty or comorbidity, have they not been treated sufficiently? And the second one is regarding your follow-up. You said you need at least 10 years, so are you planning to extend the study, the follow-up in the study?
Yeah, at the time when we started in 2004, there was insufficient evidence on the tolerability, for example, of paclitaxel in elderly patients. That information is now more available, and it shows that you can do it. But at that time, these patients were not treated. So these were patients that were not treated according to the usual standards of care that is the case for younger patients. And to your second question, the study allows to collect long-term follow-up, so we will do this.
Charles Bankhead, MedPage Today. The results would suggest that the two regimens did not differ. Would you be comfortable giving a patient just Ibandronate?
Well, as I said, taking the CLGB study into account, which showed that there was a significant improvement with EC or CMF. I believe that's more the question is can I give this patient at least an EC or maybe even an EC taxane sequence? Then I would do this. So the patient has to be really unfit before I would not give her the chemotherapy. Of course, this very much depends on the subtype. So the more aggressive the subtype, the more I will try to at least somehow give the chemotherapy.
ASCO post. So maybe to some U.S. physicians, would these women been treated like this in the U.S.? I mean, without any chemotherapy? And the second question is Ibandronate having an anti-tumor effect?
Well, if you look for in epidemiological surveys, there's still a large fraction of patients that is not getting an appropriate treatment. Even this includes even endocrine treatment, where sometimes physicians are reluctant to give for such a long period these hormones, which have cumulative toxicities. So there is still an under treatment. And regarding your second question, last year at this meeting, a large meta-analysis by the Oxford group has been presented, showing that in clearly postmenopausal patients, that means patients above 60 years of age, there was a clear preventive effect of metastases, recurrences, but also of death after breast cancer. And that was according to all types of bisphosphonates.
Hi, Ed Zussman with Oncology Times. A question on, well, there are a couple questions in my mind on this, but one, how was the two regimens tolerated?
The capecitabine was given for the full 6 cycles in 83% of patients, and the 2-year bisphosphonate period could be given to 75% of patients. So of course there are patients that either had to stop earlier due to various reasons, but also there were maybe interruptions with the chemotherapy, and also of course we observed more grade 3-4 events. I will show this in the main presentation with the capecitabine, but there was nothing unexpected. In general, it was, I believe, according to our medical perspective, we would say it was acceptable tolerance in the majority of the patients.
I'm a little confused by your recommendation that capecitabine can be used in this population. Is that based on the fact that it's tolerated rather than it's effective?
Well, in metastatic disease, we are using it a lot as a mono chemotherapy, and especially in elderly patients. Yeah, so this is where it comes from. But for the adjuvant or for early breast cancer, this study does not support to use it. There are other large phase 3 studies for capecitabine. They were more or less all negative, maybe with a trend. But so currently we don't have evidence to give this drug for early breast cancer patients, at any age, actually.
All right, then, Dr. Artiaga, we're ready for the next speaker.